Good afternoon, everybody. I'm Alan Mertz, President of the American Clinical Laboratory Association, and I'd like to welcome everyone here, especially our speakers and guests. We've had a lot of people travel a long way to be here. But also I know for the folks here who work on the Hill, I used to actually work in this building for many years, and I know how busy it is when they're in session, or any time really. So I'm really happy that you took the time to join us today. For those, we also have folks on Twitter, and we're going to ask them to join the conversation later. She's here, thank you. And we are doing a live webcast so that folks can watch and hear. The Congresswoman is here, so I'm going to introduce her very quickly. But just before we get started, this is an event that's hosted by Results for Life, and Results for Life is a nonprofit educational foundation that the American Clinical Laboratory Association, some other organizations, lab organizations started about 5 or 6 years ago. And it's really, the purpose of it is to educate policymakers and the public about the value of laboratory services. As far as lab tests go, the tests that we're going to talk about today, they really are the foundation of what I'm sure you've heard a lot about in terms of what personalized medicine is, and they're really taking the field by storm. They're creating tests that they radically change the way that clinicians treat cancer and other life-threatening diseases. It's really an incredible revolution going on in medicine, as the Congresswoman knows so well. It's a patient-centric approach. It treats the person and the specific disease, and it allows physicians to really tailor the treatment based on genetics and the molecular makeup. All disease really is molecular. It all is genetically based. And we're finally, after hundreds of years in medicine, we're really getting down to the molecular level, and we're able to diagnose so precisely about what disease we have and pick the right treatment at the right time, and sometimes decide you don't need to be treated, which is also of such great savings in terms of the health care to the patient and sometimes in dollars. But I'm not really the expert on this. We have from the physician side and the patient side, and we have a patient here today as well. And they'll really talk about what the impact has been on patients, which is really important. So with that as a bit of an introduction, I'd like to introduce our first speaker, Congresswoman Jackie Speier. She represents the 14th District of California since 2008. She's a lifelong resident of the district. She's committed to the citizens of her community, and she has over 29 years of public service. She serves on the Committee on Oversight and Government Reform. She's the ranking member of the Subcommittee on Energy Policy, Health Care, and Entitlements, and she also serves on the House Armed Services Committee. In January of this year, she was appointed to serve as Vice Chair of the new Congressional Gun Violence Prevention Task Force. And she's also, importantly for the issues today, she's the co-chair of the Biomedical Research Caucus. So, Congresswoman, we're thrilled to have you today to talk about this important topic. And so please join me in welcoming Congresswoman Jackie Speier.
Hello, everyone. It's really a delight to be here. And I think by the time you've heard these presentations, you're going to walk out of here feeling very confident that healthcare is going where no one ever thought it could go before. It is truly remarkable what you're going to be hearing. Now, we're in the middle of a roll call on adjourning, so there's a lot of shenanigans going on the House floor this morning. So I'm going to kind of truncate my comments a little bit, but to kind of put it in perspective for you, I am the representative of the heart of the biomedical world for this country. And I say that proudly, and I love to tell the story of how it all came to be, because it really speaks to the synergy that exists in the San Francisco, San Mateo, Santa Clara County region, where we have universities like the University of California, San Francisco, and Stanford and Berkeley across the Bay. But some 30-plus years ago, two guys got together at a bar in San Francisco on Union Street. And if you know Union Street at all, it's a pickup area. It's where all the young go to drink and eat. And these two guys got together and sat down, had a couple of beers. Actually, they had more than a couple of beers because they were there for 3 hours. One of them was a professor from UCSF, Herb Boyer. The other one was a venture capitalist named Bob Swanson. At the end of their 3-hour conversation, and their 3 or 4 beers. They shook hands, and they founded not just the company, but an entire industry. That company was Genentech, and the industry, of course, is the entire biotechnology, biomedical industry. And in South San Francisco, where they founded their company, in that one city alone, there are over 80 companies doing biomedical and biotechnology generally. So it is, in fact, the throbbing heart that has really expanded throughout the region. The opportunity you're going to have this afternoon to hear from Dr. Stephen Shak is really pretty remarkable. I have met him. He has done groundbreaking work for Genomic Health, where I proudly can say is in my district as well. And I heard the CEO of this great company, who happens to be a woman, speak maybe 8 years ago at an event, and I was stunned by what she said. What she said was 80% of the chemotherapy that is done on patients has no benefit. And maybe I'm saying it improperly, but in effect, that was basically the message. And when you think of all the people that end up having chemotherapy, have their lives marginalized, have the quality of their lives diminished, it makes sense for us to find out when it's going to work and why it's going to work on those patients that will best benefit from it. And that's what Genomic Health has done through its personalized medicine. It now has a test for breast cancer, for colon cancer, and for prostate cancer. And they can look at each of us individually and see, based on our genetic makeup, whether or not we will benefit from the chemotherapy. So, no point in having a round of chemotherapy if it's not going to benefit you. And that's what is truly remarkable, and how personalized medicine is going to change the way we look at medical care generally. Now, having said that, I want to remind all of you of what the head of the NIH has said, Dr. Francis Collins. He was one of the premier discoverers of the genome, of actually, coming up with what it all looked like. And for all the work that he has put into that, for the 20, 30 years that he invested into unlocking the secret about the human genome, he made a trip to China within the last couple of years, and they took him to what was previously a shoe factory, except it wasn't a shoe factory anymore. It now had more than 3,000 scientists working there sequencing DNA. And with a great deal of chagrin, he said, within 3 to 5 years, they will eclipse us. Now, that should be a warning sign to all of us that if we don't continue to fund NIH and medical research in this country like we have done historically, they will eclipse us. And when they eclipse us, the technology, the research will leave the United States and will relocate in China. And we don't want to have that happen. So it's really very important that we recognize how critical this is, not just to our personal futures as individuals who may suffer from a cancer, but to our economy as well. So I'm going to forego telling you all of these things I was going to say, because time is of the essence on a number of levels, and you really have some outstanding talent that you're going to be able to listen to, and a patient who has benefited so much from the technology that's there. So thank you all for being here.
Thank you, Congresswoman, and you did a beautiful job of weaving together all of the themes we have today. And as you said, the most important theme is what this is all meant to patients, and that's so I'd like to introduce our next speaker, Laurie Levin. We had a wonderful chance for all of us to get together at dinner last night, and I really heard the whole story. So I think you're going to find it very interesting and moving. Laurie has survived cancer twice in her life, at both age 27 and 58. She's a published nonfiction author and Harvard-trained anthropologist. And just as proof as how beautifully healthy she is and how well she's doing. She's an avid hiker, long-distance swimmer, Tai Chi practitioner, so she's much healthier than I am, actually. So without further ado, let me introduce Laurie, and thank you so much for coming.
Hello, I'm delighted and honored to be here today to speak with you about my real-life experience with personalized medicine and genetic testing. Thank you, Alan, for inviting me. I'm going to move this up a little bit, if that's okay. My story is actually very complicated, and it starts in 1977 when I was living in a Mayan Indian village in the remote highlands of Guatemala, conducting my research for my PhD. I had been coughing, I had a dry, shallow cough and some flu-like symptoms, nothing really very radical, a few night sweats. And I figured since tuberculosis was endemic in the area, I would hop on what they call a chicken bus, which literally transports chickens, and take the 12-hour ride down to Guatemala City to see a doctor. And that's exactly what I did. A day later, I was sitting in an infectious disease, a U.S.-trained infectious disease specialist, and told him my story, and he promptly ordered a chest X-ray. Now, in Guatemala, you don't get your results like that. You have to come back 2 or 3 days later. And when I did, he walked into the office, and I could tell immediately that the news was not good. He informed me that I had a tumor the size of a grapefruit beneath my breastbone, and that I needed to see an oncologist either in Guatemala City or in the United States immediately. Well, it took me about a nanosecond to decide to get on a plane, and I did so within the next 24 hours, carrying nothing more than my little backpack. I didn't go back and say goodbye to anybody in the village. I basically disappeared off the face of the earth from their point of view, leaving all of my belongings, all of my research, and I did not return until 2007. But that is another story, which I'm not going to tell you today. 2 days later, I was at UCLA, admitted to UCLA Medical Center as an inpatient. That's the way they did it in those days. And 2 weeks later, I was in the hospital for 2 weeks, I was diagnosed with diffuse, inoperable, they call it non-Hodgkin's lymphoma now, stage 3B on a 4-stage scale. Now, back then, this was kind of in the dark ages of cancer treatment, and combination chemotherapy was just being employed at that point, and that was really, in addition to radiation, my sole option, treatment option. And it involved a highly aggressive protocol that the acronym is CHOP, Cytoxin, Adriamycin, Oncovin, and Prednisone, followed by 6 weeks of radiation to the chest, at the site of my primary tumor. Now, as rough as this year was, and it was pretty grueling, I was 28, so 27, 28 at the time, so it was tolerable. I was able to bounce back fairly well. I was actually very grateful that there was a treatment, because 3 years prior, there hadn't been. And thanks to superb medical care and a very talented oncologist, who actually is still my oncologist. We have gone gray together, and that is actually a good thing. I survived my first bout of cancer and did so as you see me today, very, very well. In fact, for the next 3 decades, I enjoyed absolute perfect health. Now, you're probably saying, what does this have to do with genomic testing? How could that possibly connect? Well, actually, it has a lot to do with it, and here's why. Just days prior to my 57th birthday, I took my annual mammogram. Were you signaling to me? I took my annual mammogram, and it revealed a mass the size, about 2.2 centimeters, a little tiny one, tiny enough, in the same quadrant where I had been radiated before, previously, 30 years prior. A fine needle biopsy confirmed invasive ductal carcinoma. Now, I soon found out that I belonged to a subset of women, all of whom, or many of whom, have been radiated to the chest for their lymphoma, who years later then developed breast cancer. And although it's not directly linked to the lymphoma, it's highly likely, but it can't be proved, that it was related to my previous radiation. Now, if news of a second cancer wasn't shattering enough, more complications lie ahead. My heart sank when I was informed that because I had already reached my lifetime levels of some of the chemotherapeutic agents that had cured me the first time around, receiving them yet again would expose me to cardiac toxicity, leukemia, or both, and that my chances were far more likely than anyone who had never taken chemotherapy before. So my dilemma was this. Do I choose chemotherapy and lay myself open to these horrible risks, or do I forego the benefits of chemotherapy to protect myself? Now, at one point, I seriously considered having a mastectomy, even though I was a candidate for a lumpectomy, just so that I could eliminate this looping that I was doing about, yes, no, chemo, yes, no. I mean, it was really an agonizing and terribly, 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 terribly troubling decision. Because I didn't know how to make a good decision. I didn't have a good decision was out of my reach, just out of my reach. Now, enter Genomic Health and the Oncotype DX, which is, as you will hear from Dr. Steve Shak in more detail, a diagnostic test that helps a woman and her doctor determine if she will benefit from chemotherapy. Fortunately, I fit the test protocol perfectly. Now, at the time, all I really knew was that this was a brand new genomic tool. That's what my doctor told me. He was an early adopter, and fortunately, this was in 2005. So he would have been just hearing about the test probably within the year previous. Excuse me, I have to blow my nose. Sorry about that. And he told me about the test, and he said, look, this is a test that will help us make a decision, not on the basis of fear, not on the basis of guesswork, not on the basis of wishful thinking, but on the basis of scientific, reliable information that is specific to your unique tumor. Well, the moment I received my recurrence score is forever etched in my memory. And I remember thinking many, many things, but one of the first things I was thinking was that I was so grateful that there were men and women scientists out there working on questions, solving questions that had never even crossed my mind. And that of all of those people, I had access to that test. Now, my lucky number was 17. Now, 17 was not a super low number. I wanted it to be lower, but it wasn't, and that's just the way life is. But it was low enough for my doctor to recommend that we move away from the one-size-fits-all approach, and that he recommended an individualized treatment plan, which actually involved the surgery, naturally, the lumpectomy, immediately followed by the radiation, followed by 5 years of hormonal therapy. Now imagine, if only briefly, and I dare you to imagine this because it is a fairly terrifying exercise, but the pain and the suffering that I would have had to go through were I not able to access this test. Not to mention the huge costs of unnecessary chemotherapy, as well as a possible mastectomy and possibly reconstructive surgery. I mean, the insurance costs would have been astronomical, and all for nothing. But the benefits of the Oncotype didn't stop there. Because I was spared chemo, I believe that I was able to bounce back from surgery and from the radiation far more quickly than I would have had I taken a course of chemotherapy. It also gave me a psychological boost. It gave me something to hang on to. And although I am completely aware that there are no guarantees in life, for sure not, and I'm not a magical thinker, the number 17 is kind of like a touchstone of wellness in my life. So here I am, speaking to you today, 8 years later, and no matter how many times I tell this story, I can't help but remember that number and Dr. Sarnaw's reassuring words, for as I listened to him, I felt, as I feel today, that the Oncotype DX handed me my life back. Thank you.
Thank you, Laurie. So our next speaker was very involved in the development and founding that test. It's Dr. Steve Shak. He's the Executive Vice President of Research and Development. He was at Genomic Health since 2012 and was Chief Medical Officer since 2000 and has really been a leader in personalized medicine. He served for 14 years in various roles at Genentech. The Congresswoman referred to Genentech earlier. And prior to Genentech, Steve was Assistant Professor of Medicine and Pharmacology at New York University School of Medicine. And I think we'll just move right on to have Steve come on up. Thanks, Steve.
Well, Laura, thank you so much for your participation today and for your powerful and actually very personal remarks. That's why we are all here. There is a common bond that brings us together today. Indeed, there's a common bond that has led so many of us to choose to work in the field of health care, to devote ourselves and our lives to the care of others. We care when we see a loved one or even someone that we never met before when they are sick or suffering, and we want to do something about it. We want to do something that really works. Cancer in the last century and still too often today is treated with a one-size-fits-all approach, with a lack of knowledge, and with limited benefits to so many individuals, and also with high toxicities and great cost. Building on the breakthrough technology innovations of brilliant scientists funded in this country, such as the Human Genome Project led by Francis Collins, and new diagnostic methods such as, you'll hear this word PCR, the polymerase chain reaction, that was invented here in the United States. We founded Genomic Health in 2000, at the beginning of this new century, to develop new molecular diagnostic tests that would empower patients to be more knowledgeable about their individual disease so that they could select the right treatment based on the underlying biology and based on evidence, and not based on ignorance. As noted on this slide, again, and to those of you that are on the webinar, the slides will be made available. We have now served more than 350,000 patients with our Oncotype DX breast, colon, and prostate cancer tests. Small pieces of the tumor tissue that is removed at the time of diagnosis by surgeons in local hospitals and care centers are sent to the pathology lab where the diagnosis of cancer is made by reviewing slides under the microscope. Technology that's been around probably for well more than 100 years. But looking under the microscope doesn't tell you about the biology underlying what you see. And so now those 350,000 specimens have been sent to our laboratory, not only from every state in the United States, but also from more than 70 countries around the world. It's just great that the efforts to grow and to develop this test for women who have breast cancer in the United States is also now serving those patients who have breast cancer wherever they live. And the wonders of modern FedEx, et cetera, now allow us to do that in a way that you never could have done that 20 or 30 years ago. It is extremely challenging to develop these tests that really work, these more sophisticated assays, and it takes a variety, a number of ingredients. It takes talented people, first and foremost. It takes collaboration and teamwork. There's no such thing now as little science. There's big science, big data, and we need to develop, and we are developing better skills in being able to learn from the information we capture. It takes collaboration among different stakeholders, industry, academia, government and regulatory affairs, patient advocates. We need, and we have worked together. It would have been impossible to develop the Oncotype DX test without that team and the considerable resources and sharp focus. You can't do everything. And we have focused in order to drive this new field of personalized medicine in terms of advanced and sophisticated tests on answering the most important and critical questions that patients like Laurie have. So for invasive breast cancer, the question, do I need chemotherapy? For patients with ductal carcinoma in situ, a non-invasive form of breast cancer, or DCIS, do I need radiation? For men and women with stage 2 and stage 3 colon cancer who are newly diagnosed, do I have an aggressive disease that needs to be treated aggressively? And then finally, our newest test for prostate cancer, do I need immediate surgery? I will now share with you some important data regarding our breast and prostate cancer tests. The Oncotype DX breast cancer test is sophisticated and complicated and is run with great care. It measures the expression of 21 individual genes and generates a score that Laurie referred to. The tumor tissue is removed by the surgeon and sent to us. And strong clinical evidence now from 15 studies in more than 5,000 patients validated its results and supports its use. Many studies now have been published that described its impact in clinical practice. This slide shows an example of that impact in real patient care. And is shown here, and these are results then now from multiple studies in women who were diagnosed with breast cancer without the Oncotype DX breast cancer test. The treatment plan without the test was to offer chemotherapy and recommend it in 62% of patients. Even though, and here's a figure not everyone knows, it was recommended in the majority of patients, even though we knew that only 4 out of 100 benefited. Only 4 out of 100. I don't think that's commonly known. And that's why there was so much anguish, not just in this case, but in so many cases, and in so many cases still today, regarding what's the right thing for me to do. Well, with the Oncotype DX test, and this now shows the treatment plan after the test, you can see in the middle there a lot of those reds for chemotherapy now turn to green. A large number of women can now confidently choose to take hormonal therapy, just like Laurie did, along with good surgery and good radiation. Notice, however, there are 4 women, and it can go in the other direction, who looked like they had a tumor that was favorable, but the underlying biology revealed by Oncotype suggested that it was more aggressive disease and would have a clear, large benefit of chemotherapy. In that case, and I've spoken to women who've gotten a high score, and they say, of course, I really wished it had been low, but at least now I know that I'm taking chemotherapy for a good reason. I'm going to grit my teeth and I'm going to get through it. It goes in both directions. That's what personalized medicine is. It's about the right thing, not getting the cheapest or nothing. How about prostate cancer now? We made our test available for prostate cancer just 2 months ago. You are probably very aware with all the publicity about the controversy regarding PSA, the limitations of prostate cancer screening. The PSA test does identify patients who might have prostate cancer, but it doesn't tell us whether it's bad or good. Which are the aggressive ones? Which are the ones that need immediate treatment? And which are the larger number of ones, in fact, that can actually avoid invasive surgery. Based on PSA screening, more than 1 million biopsies are done this year in the United States, and 250,000 men will be diagnosed. But did you know that half of them are low risk, with less than a 3% chance of ever progressing or having life-threatening prostate cancer in their lifetime? Thus, as shown here, most prostate cancers, 97%, are low risk. But because we didn't know which ones were low risk, truly low risk, that we could be confident in that, it turns out that 10% or less men actually choose active surveillance, and more than 90% choose immediate surgery associated with significant side effects for a lifetime. Well, now there's a test. The UCSF prostate cancer group, led by Dr. Peter Carroll, a world leader in prostate cancer research, presented the results of his validation study at the AUA, the American Urological Association meeting in May of 2013. He spoke about how this is going to improve treatment for patients with prostate cancer, and it does so because we focused, and together with the Cleveland Clinic and with UCSF, did a number of things that had to be done in order to be able to make this test available so that it could actually direct patients to the right treatment. We needed to study relevant population, show the pathways that mattered, find new genes. It was a different set of genes in the breast cancer test. And again, do the studies that answered the critical questions that were key in order to think that this was a test that now should be used. Laurie's individual story highlights how critical it is to get the right diagnosis. We are proud that our diverse and talented employees in California, here in America, are leading the world in this new field. Everyone knows that drugs can be life-saving. Tests are life-saving too. This new personalized medicine industry focused on developing sophisticated new tests is fragile. We ask you who have joined us today to pass it on, to continue to learn more about this new field and how smart policies can facilitate our country continuing its leadership and, more importantly, to continue to improve the lives of the patients we serve. The best is yet to come. Thank you.
Thank you, Steve. I'd like to now introduce our next speaker, Nancy Davenport-Ennis. Nancy is one of the nation's leading patient advocacy experts on issues related to patients' healthcare access challenges. In 1996, she founded the Patient Advocate Foundation, which provides professional case management services to millions of insured, uninsured, and underinsured patients. And I think I'm going to expedite my introduction. We're running a little behind, and because Nancy, we'd love to hear from you. Thank you.
So I stand before you as a 24-year cancer survivor. And I want to share with you that the co-founder of our organization and my husband, Jack Ennis, who is in this audience, is here as a 9-year cancer survivor of stage 4 metastatic disease. I also want to share with you that neither of us had access to a genetic test that could help us make the decision. So 24 years ago, the determination of whether to have a mastectomy or not was one simple question to one surgeon at Duke University Medical Center by my husband to him: what would you do if this was your wife? And he said, to be certain that I could save her life, I would do surgery. And 6 months later, when I was diagnosed with a second primary in the opposite breast, the same question was asked again, and the same answer was given. Had we had the opportunity for personalized medicine 24 years ago, I am a DCIS breast cancer patient. All of that could have been avoided, could have been a far different change. Today, American patients, we have over 1 million people in America who are going to be diagnosed with cancer this year. We have over 12 million survivors of cancer in the United States of America, and each and every one of them have a higher risk of developing cancer again than those of us who have never had it. With genomic testing, we have the real opportunity to make personalized medicine personal for every single one of the 1 million patients. We have the opportunity to reduce cost. We have the opportunity to reduce burdens to families pushed into bankruptcy today because we race down the trail of therapeutic interventions often that take every resource that family has. If we're going to begin that journey, let's make the decisions deliberately. Let's have a genetic test. If the genetic test settles for colon cancer is KRAS, and you come back and tell me that I've tested positive, then I know what therapeutic intervention I need to proceed with. If you don't do that for me, you're like one of our patients that we worked with just last week, a 35-year-old father of 4 in the state of Virginia, diagnosed with colon cancer. No one hit the pause button to recommend a genetic test. Rather, we raced into therapeutic intervention that was inappropriate. the disease advanced. He now has liver mets, and the procedure that he needed to manage those is only being done right now at Memorial Sloan Kettering. And so we fought valiantly to get this 35-year-old father of four to Memorial Sloan Kettering to have the therapeutic intervention. The costs are enormous. The burden to the family, it's enormous. If we had just hit the pause button long enough to have one genetic test run, we could have likely intervened with the appropriate therapeutic intervention at the time of diagnosis and saved all of that suffering, all of this trauma, and all of this expense. Medicine is changing in America, and for the cancer community, it's changing dramatically. But as one who has worked in policy in Washington since 1982, I must say to each of you who work in this city every day, with you and your bosses trying to make a difference for 300 people in America, it begins with you. The scientists can race down that bench, and they can bring discoveries to market. And if we do not create a system of reimbursement that is supportive of the research and the development, we're not racing anywhere. We're racing to dead ends, and it's costing us $1 billion for each of those dead ends. So what we need from our friends in Washington is for you to approach the issue of personalized medicine and genomic testing the same way you would approach it if it were your family member diagnosed this afternoon. And there's only one simple question that needs to be answered. If my loved one was diagnosed this afternoon with cancer, would I want the opportunity for one genetic test that might define the therapeutic intervention most likely to save a life or extend a life with quality of care? That's the question. And for us to answer that question successfully, we need your help. I'm often asked, do you have a lot of patients? You have millions of patients who contact your foundation every single year. We closed last year over 109,000 cases. We had over 4.2 million people who contacted us for some other form of help. We collect, as all of you in this room who have worked with us know, 260 primary fields of data for every single patient that we serve. We can tell you very concretely what's happening with them, whether it's financial and what they look like. So let me tell you what the patients who have reached out to us for help in getting a genetic test look like. 80% of those patients were breast cancer patients, and they were having difficulty getting reimbursement for a BRCA1 or BRCA2 gene test. Let me share a personal story there. We have a 39-year-old healthcare executive. Mother is a breast cancer survivor. This executive at the age of 39 determined that she would summon up the courage to go and get a BRCA1 gene test done. She arrived the day of the test with the support of family members and was told at the counter, your coinsurance for this test is $900. This national healthcare leader said, quote, this gave me yet another excuse not to have a test that I was already frightened to death to have because I didn't want to hear what I might hear. So we as a nation, and you and your bosses in this city, have a real opportunity to look at what we are doing with reimbursement for these tests and to try to make them affordable. Sometimes when we invest a little more on the front side, we can save tremendously in human suffering and dollars on the back side. Only about 10% of our people who came to us were trying to get PSA testing. 5% were trying to get reimbursement for CA-125 lab test. And about 5% of our patients were coming to us for EGFR testing. 70% of our people looking for genetic testing were doing that in light of a cancer diagnosis. And the other 30% were trying to screen for symptoms. If we look at what the cancer diagnoses were for the patients who came to us for support and reimbursement for these genetic tests, the largest family of patients, breast cancer, is 64.3%. 14.3% were prostate cancer. Adenocarcinomas were only 7%, as were basal cell carcinomas and ovarian cancers. If we look at the location of these patients, 43% live in suburban America. If we look at the urban figure, it goes to 35%. But when you move to the rural community, as we would all expect, that number drops to only 15%. So I know that we have work to do in that population and with the medical community and getting those folks help. There's huge disparity in the ethnicity of the people that are reaching out to us for help with genetic testing. 65% of the people who reached out to us are Caucasian. Only 15% are African American, 15% are Hispanic, Latino, and the other 5% fall across all of the other ethnicities. The interesting thing that we found is if you look at the age of the patients who were seeking support from us, 15% of them were between the ages of 26 to 35. It's an important number for this audience. I suspect none of us would have thought 26 to 35 would have 15% of our representatives. 36 years old to 45-year-olds comprised 31% of the people reaching out to us for genetic testing. And if you go to the 46 to 63 categories, that's where 47% of the age groups fell. And if you look at the income levels, the household income levels of the people seeking help, 15% of those households had income under 11%. However, if you go to the 48,000 to the 59,000, 20% of those callers were calling to get help for reimbursement for genetic testing. So as you continue to learn more about personalized medicine, and as you continue to counsel your boss in different legislative proposals that are being made, there are only two touch points that I would ask you to consider in that discussion. Number one, will it save suffering over long spans of time that will result in absolutely nothing beneficial? And if I allow this test to happen, do I have a greater opportunity to invest for a test and perhaps get the patient on the pathway to appropriate intervention? And the second touchstone, I would simply ask you, make the decision with your boss on a personal level. If it's you diagnosed this afternoon at 30 years of age, do you want access to reimbursement for the test? And do you want to make your decision of what to do based on a genetic test? Thank you for the opportunity to visit with each of you, and thank you for your referrals to Patient Advocate Foundation also. Thank you.
Okay, have Nancy and Steve come up for just a few minutes in a panel discussion. While they're coming up, I just want to remind the audience our association represents many different kinds of labs, and we don't want to leave you with the impression that genetic testing is only involved in cancer. It's actually very involved in infectious disease, for instance. Some of the great breakthroughs in the treatment of HIV and making it a chronically manageable disease, and why people are living in part was because of the incredible advances going back actually into the 1990s and viral load and drug resistance testing. It really turned the corner in combination with the right drugs. So it's not just cancer, as Steve knows. And actually, we'll invite questions for those. Right? Do we have any questions from on the web? Or okay, I'll let Kim start. Go ahead.
I'm Kim with Genetics. We're the sole provider of the BRCA testing, and I was curious as to whether the patient was actually able to receive testing or financial assistance.
There was really not the need for financial assistance.
So she was able to afford it.
She could afford it. In this particular instance, it was a psychological impact. And I think with genetic testing, people, they're still are issues with people embracing the genetic testing process. And as we can integrate it into the population as a routine part of making your decision of what you should do therapeutically before you get started down that road, I think that people will begin to say whatever that cost is, they want to bear it.
Are you aware that under the Affordable Care Act, that BRCA testing is actually mandated with no cost sharing for all non-grandfathered plans?
As an organization that worked fairly deliberately on that legislation in this city, yes, we're aware of that and delighted.
Good. Well, then more women who are faced with that will then have no cost sharing involved.
Absolutely.
Kim, thank you for asking that. Okay, let me open it up to other questions. And while you're thinking of your questions, actually, Steve, I was going to ask you a question to see sort of where we are in the continuum of genetic testing. Is the wave of genetic testing and innovation, is it the beginning, the middle, the end? Is it cresting? Are we just starting to realize the growth potential? Where do you see us on the continuum of this?
Well, it's definitely the beginning. In the way I would say it's sort of the end of the beginning, which is good. I mean, sometimes you have fits and starts in the beginning. It can be pretty rocky. There's a lot of misinformation. You have to go out and educate and tell a story because the story had never been told before. And I remember 5, 6, 7 years ago, it was, Oncotype what and Genomic who. So those days I think are behind us, but when we think about the impact, maybe there are two ways to address how big and important this has got to be. One is if we look at the efficacy of existing cancer drugs. On average, the number published by a number of groups is that about 20% of people benefit on average. And for some drugs it might be a little lower, for some it might be a little higher. Well, if we're spending $80 billion a year on cancer drugs, it means we're spending $60 billion unnecessarily in addition to the side effects and the toxicities that accompany every drug. So clearly, there's much more work to be done there. I believe as a scientist, and most of my colleagues I think would agree, that every drug is targeted. We just haven't figured out yet how to target it. And so in that regard, there's much more work to be done. I think the other thing is really the issue of education and access, is we're not at all where we need to be with regard to either education or access. I think for people to feel empowered and to, all drugs, just like all drugs are not good drugs, all tests are not good tests. And so they're not all the same, just like all tumors are not the same. And so we also need to become educated and tell the story and educate ourselves about what are the criteria that distinguish the tests that should be used and in which setting, and what are the ones that shouldn't be used or yet are unnecessary or don't have the evidence. And so in that regard, it's still the beginning. But in each case, if I look back and think about Swanson and Boyer 30 years ago, starting the biotech industry, they started as well, and there was a lot of fear about biotechnology in those early days 30 years ago. And I think even they, as the big dreamers and the incredible people that they were, probably didn't see how big the future could be and would be just delighted to now see. Unfortunately, Bob Swanson himself succumbed to brain cancer himself, and his life was cut short so that he hasn't had a chance to see it. But I think that's the same for personalized medicine. It is going to be that big.
All right. We had a question come in from Twitter, and I think this probably is to Steve. How has genetic testing impacted healthcare delivery?
That's a big question. I've learned that healthcare delivery is really complicated. But the story I like to tell is what's at the heart of healthcare delivery. At the heart of healthcare delivery is that conversation in that office, between that patient and the healthcare team. Often it's the healthcare team the patient and the family, the loved ones who are there in the office together. And at the heart of it, I think we're going to solve all of these very difficult problems by never losing sight on that our job with our healthcare system is to put those people in a place to sit there with a tough problem and make the most informed, the best decision that they can make about what's going to, potentially reduce their suffering, save their lives.
Actually, if I could build on, build on that question a little bit.
So absolutely, in the old days in medicine, you had a stethoscope, you could listen to a little bit of information. You really didn't have much, either as a patient or as a physician, to be informed about what the right thing to do is. Well, that's now changing, thank God.
Having worked up here and knowing now the pressures of cost-cutting in health care and their pressures to reduce Medicare spending and so forth, can you talk a little bit about the cost of the test versus what the cost of treatment would have been? And I know it's so much more about the patient, but cost containment is a big issue here. So with breast cancer and with prostate cancer, and both of you could address this, but what are the savings to the system potentially?
The cost of the breast cancer test is about $4,000 for the test. And in multiple studies that have looked at the cost effectiveness of using the test, since chemotherapy and the toxicities of chemotherapy are so costly, actually up to $2,000 per patient is saved every year, every patient, by the use of the test. So the Oncotype test has saved the Medicare, hundreds of millions of dollars now since it became available.
And of course, in the case we had with Laurie, it saved the cost of potentially mastectomy and surgery and all the related cost of that. So, Nancy, would you like
And then a couple of other costs I would talk about, while CBO won't score these costs, but they're real for all of us in this room and we know it. Often when you can have the test and you intervene appropriately with the correct therapeutic intervention to start with, you can keep people employed. They can maintain their day-to-day responsibilities. They can take care of families. They can have their individual autonomy. And so you don't see families, and even cross-generations in families, losing cross-generational assets. So the savings are significant in many of the underlying cost of living issues that patients are confronting. As well, we need to be reminded all costs for health care, the patient is bearing a portion of that. And that portion can be anywhere from 20% up to a 66 or 70%, depending if they're on a branded drug and it's sitting out on a specialty tier. So that's something else that's really important.
It's probably too soon with your prostate test. It just came out. But as we know, the amount of unnecessary surgery and radiation that may be you have a lot more watchful waiting now, which is much better for the patient, but obviously is going to save money. I think, unfortunately, we're out of time. This has been fantastic. I wish we could go another hour. But I want to thank our panelists for being here today and the audience for coming. And again, thank you very much. And if you need more information, our website is labresultsforlife.org is RFL, or the ACLA website is acla.com. Thank you very much.